number 7, that is Dr. Arvind Kumar Morya, is going to give us an idea on tips and tricks for management of successful Phaco and pseudo-exfoliation syndrome. Over to you, Dr.
Yeah.
Arvind.
Good morning, my dear friends, and thank you, AIOS, for giving me the opportunity. So my talk is on tips and tricks for management of successful Phaco in pseudo-exfoliation syndrome. So it is known as a disease of Vikings, and it was in 1917 that John Lindbergh first identified this syndrome, and Georgiana Devok Theobald gave this pseudo-exfoliation name to this disease. And the incidence varies 0% in less than 49 and 6.25% in more than 80 years of age group, and it is more commonly seen in the Swedish population. So it is a age-related, genetically determined because of the LOXL1 gene, environment-related multifactorial systemic disease, and there is deposition of whitish gray pseudo-exfoliation fibrillogranular amyloid-like material in this disease, and it has highest prevalence in Scandinavia and in cold region, but we are seeing all these cases every day in our OPD. So pathogenesis is the jonular weakness because of the proteolytic disintegration, then the poor pupillary dilatation, and the accumulation is at the endothelia, anterior capsule, iris, trabecular meshwork, lens jonules, heart, lung, liver, kidney, meninges, and blood vessels. Other complications are secondary to weakened suspensory ligament. So there is unstable crystalline lens during the surgery, vitreous loss, and nucleus luxation and decentration of the intraocular lens, and secondary to atrophic changes of iris stroma and sphincter. So there are trans-illumination defects also. And because of secondary to poor blood aqueous barrier, post-op flare and fibrinous reaction are commonly seen. Then secondary open angle glaucoma are also seen in the pseudo-exfoliation syndrome. So these are the surgical implications. So first is the jonular weakness, poor pupillary dilatation, and capsular phimosis. So to tackle poor pupillary dilatation, we can give NSAID after instilling the proparacaine, and during the block, hypertony needs to be there, and choice of IOL, one-piece hydrophobic heparin coated, and IV cannulation needs to be there because sudden hypertony is observed in few of the cases. So for the corneal haze, HPMC 2% can be used, and shallow AC, visco sandwich technique, and post-operative capsular phimosis. So we need to have a larger axis, and non-dilating pupil, of course we need to opt for the iris hooks or rings. Floppy iris, again moderate use of viscoelastic, and for jonular weaknesses, step down phaco, direct chop and stop, and CTR and Sione ring needs to be kept ready. Post-op period, multiple and long follow-up is required because capsular phimosis chances are there, decentration of the intraocular lens, and rise of IOP because of the secondary open angle glaucoma. So this was one of the case. So it was a pseudo-exfoliation along with open angle glaucoma. So at 3x3, this scleral incision was given, and depth of half of the depth of this. So I dissect it using the crescent. So you can see how much is the corneal haze. And this trypan blue needs to be pushed under air so that the integrity and the endothelia is saved because of the toxic effect of the trypan blue. Then our axis was made of 5.5 millimeter, and routine hydrodissection and delineation, and stop and chop phaco was done under very low parameters. So at this time you can see there was jonular dialysis as I was aspirating the cortical matter. So CTR was pushed from the opposite quadrant, and then hydrophobic IOL was implanted very gently and very slowly. So in conclusion, cataract surgery in pseudo-exfoliation syndrome, although challenging because of weak jonules, compromised endothelia, and poor mydriasis, can be managed with meticulous planning and early detection by the ophthalmologist, and the appropriate management at this center or timely refer to higher centers. Long-term follow-up is required for secondary open-angle glaucoma and to look for the capsular phimosis, and awareness camps regarding this pseudo-exfoliation syndrome is a must, and work in tandem with the NGOs for providing care at an economical range and not compromising with the quality care. These are my references. Thank you so very much.
Thanks a lot, Dr. Arvind. Fantastic presentation. Very good tips. Navneet, you would like to share any tips for pseudo exfoliation? There are a lot of juniors around. He is a teacher, Dr. Navneet Toshniwal.
In pseudo exfoliation, generally because of the zonular weakness, we are avoiding the hydrodissection. Completely no hydration, no rotation, and most of the time we have to remove the pieces in situ and just lift out of the bag. That's the mainly trick to avoid the zonular. Still more weakness.
Dr. Mohanta, sir, you would
Thanks.
like to comment?
Is Dr. Monta? Yeah. Monta, sir.
Pseudo exfoliation.
Hello.
Phaco and pseudo exfoliation.
He is one of the most high volume surgeons on YouTube.
Okay.
He must be a very good teacher and a scientific committee member. Yes, sir, over to you.
Yeah. In pseudo exfoliation, there can be people can be small. In those cases, pupil expansion devices should be used, either iris hook or PX, whatever is the surgeon comfortable with. And then rexis, if the zonule is weak, we cannot do a large rexis because then there can if it goes into the zonule, then it becomes difficult. Moderate about 5 millimeter rexis, and hydrodissection I do, and I rotate the nucleus bimanually, not with just pushing with on hook. Bimanual rotation I do, and it helps in those cases.
Thank you.